we've got a clinical case, my beloveds. 22-year-old medical student undergoes a routine checkup before donating blood, of course. He reports no complaints and his general conditions is good. So what's the problem? On examination, mild jaundice of the sclera and skin is noted. Okay. History: jaundice has occurred occasionally after stress, exam, and lack of sleep. Okay, lab results. Total bilirubin 38 millimole liter, elevated. Direct bilirubin 6 millimole liter, normal. AST, ALT, ALP within normal limits. Now okay. Liver and biliary tracts ultrasound normal. Question is, give me questions. What is the most likely diagnosis? Gilbert syndrome, Gilbert syndrome, it is. Viral hepatitis, no. Cholelithiasis, gallstone, no. Liver cirrhosis, no. Hemolytic anemia, no. Of course, correct option is Gilbert syndrome. Why Gilbert syndrome? Isolated mild unconjugated hyperbilirubinemia. Okay? In analysis, we see that. Direct bilirubin is normal. What else? Triggered by stress, fasting, or lack of sleep. Normal enzymes, AST, ALT, ALP, and structural liver disease, no structural liver disease, and fits the case perfectly. So Gilbert syndrome. Why other options are incorrect? Viral hepatitis B would present with elevated AST, ALT, often 10-20 times more normal in acute cases. Patients may report fatigue, anorexia, nausea, or dark urine. We've got nothing. Ultrasound may show hepatomegaly. Actually, it's not always, but anyway. So our patient has normal enzymes and no systemic symptoms. What else? Cholelithiasis. Of course, it's incorrect. Typically cause obstructive direct hyperbilirubinemia. Hyperbilirubinemia if a stone blocks bile flow. Labs, we would have more direct bilirubin, high ALP, high GGT. Clinically, collically right upper quadrant pain, nausea, sometimes fever. Ultrasound would usually reveal gallstones, of course. Our patient normal ultrasound, indirect bilirubin predominance, no pain. Liver cirrhosis, also incorrect. Cirrhosis causes chronic liver failure, low albumin, high INR, portal hypertension, and splenomegaly. Lab, mixed or direct hyperbilirubinemia, abnormal enzymes. Ultrasound, nodular liver, of course, enlarged spleen, ascites. Our case, what we've got, normal labs, and ultrasound, no stigmata of cirrhosis, absolutely. Yes, and hemolytic anemia. Actually, good question, but it's also incorrect. Hemolysis increases indirect bilirubin, but always with anemia, reticulocytosis, high LDH, and low haptoglobin. Patient may complain of fatigue, pale or dark urine from hemoglobinuria. From hemoglobinuria, we've got dark urine. Our patient has normal hemoglobin and no hematologic signs. Period. So what's our conclusion? Of course, Gilbert. Only Gilbert syndrome, or sometimes pronounced Gilbert, I don't know how to pronounce, Gilbert. Only Gilbert syndrome explains isolated, unconjugated hyperbilirubinemia with normal liver function tests and recurrent mild jaundice triggered by stress. Period. It's a Gilbert syndrome. Okay, understand. Very good. Stay blessed.